over to you. Good evening, everybody. I can see 153 people who already joined. So good evening. I'm sorry for this delay because of the problem of connectivity from Vedanta. I think we are all there. So the topic today is to talk to you about endoscopic ultrasound. Gone are the days when the endoscopic ultrasound is an optional part of your training or your clinical practice. Now it is an essential part of your training. It will be asked in the examination, and of course, it is a very integral part of any GI practice now. So I thought this will be the right platform to talk to you about some basics of endoscopic ultrasound. There cannot be anybody better than Rajesh Puri, who is a very senior consultant and one of the chairmen of gastroenterology at Medanta Hospital, Gurgaon, to address to this. And he will be discussing the basics of endoscopic ultrasound. I'm also happy to welcome the moderator for this particular program, and this is Dr. Nikhil Sonthalia, who is working at Apollo Clinicals Hospital as a consultant. He had his initial training in Mumbai, and then he was trained in advanced endoscopy, including ultrasound, in Hong Kong. He also had a brief stint at USA in Boston. So welcome, Dr. Nikhil Sonthalia and Dr. Rajesh Puri. And Rajesh, you have about 40 minutes of presentation, and then we can take up some questions. The chat box is available for anybody to make some comments or questions. Nikhil, you want to make an initial comment before Rajesh starts?
No, I think we are all set for this exciting talk. Thank you, Rajesh, for accepting the invitation. So I request you to start the session. Thank you.
So
Yes,
thank you, Dr. Mahesh Goenka, sir, and thank you, DNB, for giving this opportunity, my dear friends, Dr. Santhalia. So I know that today we have a DNB student, and I thought that I'm going to talk briefly about the current indications and uses of endoscopic ultrasound in the GI practice. It's a huge topic, so I'm going to just touch upon you, and you know that what are the indication when you should subject the patient for endoscopic ultrasound. All SOJ or all cystic lesion of the pancreas may not necessarily require endoscopic ultrasound. So next 45 minutes, I'm going to talk about the indications, uses of endoscopic ultrasound, where it is useful in GI practice. So if you look at the EUS in GI practice, it started 40 years before, and it was like a white elephant. It was in the room, anybody can see, and it's a huge investment, but it is difficult for the people to understand where to use it, how to use it, what will be the future. But in next 40 years, it will become a race course horse who has won many of the victories on his name. And similarly with the endoscopic ultrasound, which was a dark room procedure, enter into the integral part of the GI practice. We have come along the 40 years from the large scope which can produce a pain in the hand and the neck to the best available scope in the world, like the telephone which was situated at the home, we have got a decent mobiles which are integral part of our day-to-day life. So I think endoscopic ultrasound is an integral part of the GI practice. This is the image which was published in Lancet 1980 of the black and white image to the latest HD images where we have an endoscopic ultrasound, we have got elastography, we have a contrast EUS, we have a Doppler facilities and the biopsy facilities. So the needles has also gone right from the FNA needle to the true cut biopsy needle we have, and we can give the histopathological diagnosis. So we are moving from the fine needle aspiration to the histology. So endoscopic ultrasound not only has grown in the form of the scope development, but also there's a development of the accessories as well as indications. So the two kinds of endoscopic ultrasound available, the radial and the linear. First of all, it is important for the DNB student to understand what is the difference between the radial and the linear endoscopic ultrasound. This is the ultrasound, this is the endoscope where the ultrasound probe is attached, and it is scanned perpendicular to the shaft of the scope and give 360-degree view. While the linear scope is scanned parallel to the shaft of the scope and give around 110 degree of the view. So you will see the complete length of the needle with the linear EUS. So the radial EUS is a diagnostic scope. the linear endoscopic ultrasound by which you can do all therapeutic scopes, all therapeutic purpose. For the beginners, you are going to buy within few years to buy many of you are going to buy the endoscopic ultrasound machine. And I request the most important scope is linear scope, not the radial scope. Yes, if you have got money, then you can buy both, but you cannot do the therapeutic procedure with the radial scope, you can do with the linear. Recently, we have got a forward wing scope which has a bigger channel, but there is a lack of elevator facilities which is present in the linear endoscopic ultrasound. But radial is useful. The forward wing endoscopic ultrasound is useful in certain condition. So as a student, you should know we have got a radial, linear, and forward viewing, and we have mini probes also. These mini probes are in a frequency of 20 to 30 megahertz. Generally, the radial and the linear is available in 7.5 to 12 megahertz, and the mini probes are available in 12 to 30 megahertz. So you can delineate the submucosal lesion or the smaller lesion or the intraductal lesion very nicely. So these mini probe can be used from the biopsy channel of the upper GI scope, or for the CBD exploration, for the CBD knowing, you can use over the wire through the ERCP scope. So we have a radial, linear, forward wing, and the mini probes. And the main role of mini probe, they are high frequency, so they are better for the wall pattern layer as well as for the smaller subepithelial lesion, or the T1 stage of the cancer or the T2 stage of the cancer can better delineate with the mini probes, and the intraductal CBD as well as pancreatic duct evaluation can be done intraductal endoscopic ultrasound. There is another probe which is called as blind probe by the Olympus, which is not frequently used. Equipment which you should be aware. Now the question comes, why we are talking about endoscopic ultrasound, how it score over the CT. The endoscopic ultrasound give the 5-pattern layer of the gut wall. Our gut wall, you know that in pathology consists of 5 layers. An endoscopic ultrasound give the 5-layer structure of the gut wall. This is the interface. This is the musculus mucosa. The white third layer is submucosa, then musculus propria, and the adventitia or the serosa. The advantage is the T staging of the tumor can only be done best with the endoscopic ultrasound, not with the CT scan, not with the MRI, not with the PET scan. That's number one. And number second, the subepithelial lesion originating from which layer, so you can plan about their treatment. Does this patient require endoscopic, that is ESD, or patients require surgical intervention, you know about with the help of endoscopic ultrasound, because it gives the 5 of the gut wall. EUS is a very safe and accurate procedure. It can be done as an outpatient procedure, does not require general anesthesia, can be done like in any endoscopic procedure, no radiation exposure, and the beauty is the lesion as small as 5 millimeter can be FNA with the help of endoscopic ultrasound. When we talk about the uses of endoscopic ultrasound, we have got I'm going to touch upon each one by one. In the gut wall, I talked about the staging of the cancer as well as subepithelial lesion, biliary tract, dilated CBD, CBD stone, cholangiocarcinoma, in pancreas, recurrent pancreatitis, chronic pancreatitis, pancreatic mass, and cystic lesion of the pancreas, and other like lymphadenopathy of any reason, mediastinal or intra-abdominal, ascites, liver, SOL, or the vascular therapy can be done. When we talk about the interventional FNA, which is the most important part and most important use of endoscopic ultrasound, now we are not only doing the FNA, we can give the histology also, the drainage of pancreatic fluid collection, drainage of the bile duct in the failed ERCP, drainage of the gallbladder or drainage of the pancreatic duct is possible, celiac plexus neurolysis in the advanced cancer, tumor tattoos, fine needle inspiration, ablations, vascular intervention, and gastrojejunostomy. So you take any number. The most important thing for the DNB student, which I want to highlight, because many of the time referral comes with a mesenteric lymph node. You can only take FNA from the periluminal structure, around the esophagus, around the stomach, around the duodenum, and around the rectum. These are the area where endoscopic ultrasound can reach. So any esophageal lymphadenopathy or mass, perigastric lymphadenopathy, or perigastric structure like gallbladder, pancreas, can be very well tackled, or perirectal structure can very well tackled. Now, when we talk about the mediastinum, you know that mediastinum is a domain of the respiratory, but posterior mediastinum, as a gastroenterologist, we can very well reach. And the most important indication of endoscopic ultrasound is the lung cancer or mediastinal lymphadenopathy of any cause. In our country, the tuberculosis is the commonest cause. We can take FNA. Earlier, imaging of the mediastinum was done with the non-invasive method like CT scan, PET scan, or MRI, but they cannot give the tissue diagnosis. And in the evidence-based medicine, you cannot start the treatment that is it a tubercular or is it a metastatic lymphadenopathy. You have to take the specimen, and for that, we have invasive methods which are either too invasive and too costly in the form of thoracoscopy or mediastinoscopy, or transbronchial FNA and CT guided FNA have more complication and the yield is not more than 40%. So for taking the tissue from the mediastinum, either the imaging modalities are not giving the tissue diagnosis, or they have a poor yield, or they are more invasive and more costly. When we talk about endoscopic ultrasound, look at here. This is the lymph node. This is the esophageal wall, which is 3 millimeter. This is a transducer. So this patient, young patient, presented with the pain, chest, fever, and the joint pain. And you see a homogeneous lymph node. When the FNA and histology was taken, they shows non-caseating granuloma. Patient ACE level and the calcium was high. Patient was diagnosed as a sarcoidosis and the treatment was started. So any periesophageal lymphadenopathy, under reasonable guidance, you can take the FNAC. And not only that, the small lymph node of 5 to 6 millimeter can also be FNA. So advantage of endoscopic ultrasound in the mediastinum, staging of the lung cancer, getting the tissue diagnosis from the smaller as well as larger lymph node without any complication, without risk of radiation exposure. So in mediastinum, the most important role is lymphadenopathy of unknown origin, or patient with the pyrexia or staging of the lung cancer. Endoscopic ultrasound is the best modality, and combination of endoscopic ultrasound and endobronchial ultrasound give the complete mediastinoscopy, and which is the gold standard, which replace the mediastinoscopy in the lung cancer staging. We know that we are not the lung specialist, but EUS and EBUS give the complete mediastinoscopy. When we talk about the role of submucosal lesion, we all as an endoscopist come across with the submucosal lesion. We are not very sure what is the nature of submucosal lesion. Overlying mucosa is normal, and it is difficult to, when you take the biopsy from the mucosa, the biopsy is negative. It is difficult to know what is the nature of the submucosal lesion. So EUS differentiate, is it an extramural or intramural? It gives the diagnosis on the basis of nature of lesion or the echo pattern. It differentiates between the benign and malignant. It helps in getting the tissue diagnosis. And by knowing the nature of the lesion, you can plan, does this patient require observation? Does this patient can be subjected to endoscopic treatment or require a surgery? And when you compare EUS with the conventional imaging, EUS score, I'm not going into the literature. You just know that as a student, submucosal lesion endoscopic ultrasound, either with the help of mini probes or radial or linear scope, you know. If patient has a GIST, CT scan to be done for knowing about the distant metastasis, for knowing about the nature of the lesion, getting the tissue diagnosis, EUS is the best. It gives the location, it gives the size, because what we know as an endoscope is the intraluminal size we can, but what is extraluminal we don't know. So the exact size of the lesion we know with the help of endoscopic ultrasound, from which layer it is originating, what is the morphology, prediction of the nature, we can plan about the treatment. So look at these photographs of the submucosal lesion. Here there is a submucosal in the fundus on EUS, it is a compression from the spleen. Here there is a submucosal lesion in the pyloric antrum, which is the pancreatic ectopic pancreas. Here submucosal in the fundus is patient is having a ectopic varices. So if you take the biopsy, if you don't have an endoscopic ultrasound, patient might bleed to death. Here submucosal lesion is a lipoma who don't require any treatment, who don't require any follow-up. You tell the patient is a benign lesion, you don't require any follow-up. But such kind of lesion which require a surgical or endoscopic treatment, and here is a duplication cyst. So endoscopic ultrasound help in knowing the nature of the lesion, layer of the origin, extramural versus intramural, help in getting the tissue diagnosis. So this is one of the second part of the duodenum. There's a lesion which shows a hypoechoic originated from the fourth layer with adjacent lymphadenopathy, and which showed it was a GIST. Patient was subjected to surgery, and this is the histology confirm about the patient is having a GIST lesion of the duodenum. So this is why this is important. On endoscopy, on CT scan, it is very difficult to know the nature of the lesion. So endoscopic ultrasound is very useful. Similar kind of lesion you look at here, this patient presented with a GI bleed. Second part of the duodenum shows some mucosal lesion. On EUS, this patient has a whitish originating from the third layer. It was a lipoma. The lipoma was bleeding, ESG was done, and patient was cured with the treatment. So if you know the lesion, you can plan, does this patient require endoscopic treatment? Does this patient require a surgical intervention? I think EUS is very useful in SMT. So in exam, if you in your examination, if you come across SMT, if your examiner asks, what is the investigation of choice? I think endoscopic ultrasound, it gives the morphological appearance, it gives the size, layer of the origin, it gives the tissue diagnosis. These are the few other. Look at here, there's a duodenum submucosal lesion, duodenum submucosal lesion. The difference it is originating from the first layer, it is carcinoid, and here it is originating from the fourth layer, which is GIST. So the plan of the treatment is completely changed. Here you can remove endoscopically. Here it is originating from the fourth layer. Patient has to go with the surgical intervention. Another patient, fourth layer lesion, endoscopy submucosal lesion. Look at here, there's a large lesion which has an anechoic spaces that indicate this patient might have a malignant GIST. FNA was taken, just prove about a GIST, and patient has no adjacent lymphadenopathy. This patient require a local wedge resection of the stomach. So for the submucosal lesion of the GI tract, endoscopic ultrasound is the investigation of choice. When we talk about the pancreas, I always think that for pancreatic lesion, EUS is a one-shop shopping. It gives the diagnosis, it gives about the treatment, and it also helps in planning about the management plan. So for the role of EUS in chronic pancreatitis, biliary pancreatitis, and unexplained abdominal pain, pancreatic SOL, EUS has significant role. When we talk about the recurrent pancreatitis, one of the causes early chronic pancreatitis, and EUS can give the idea by knowing the parenchymal changes and the ductal changes. As a DNB student, it is important for you to know about the early chronic pancreatitis changes, hyperechoic foci, hyperechoic strain, lobulation, and the calcification in the pancreatic parenchyma. These 4 pancreatic parenchymal changes and the 5 ductal changes, pancreatic duct dilatation, ductal irregularities, hyperechoic pancreatic duct, visible pancreatic side branches. Out of these 9, if the 4 criteria is present, then you can say, yes, this patient has a possibility of chronic pancreatitis. You can prognosticate the family. This recurrent pancreatitis could be because of the early chronic pancreatitis, and within few years, this patient is going to develop chronic pancreatitis. And when you compare with the CP, EUS has a higher sensitivity and specificity in comparison to all available modalities. And these are the changes you look at here. These are the pancreatic ductal changes. This is the hyperechoic foci, strain, and lobulation. You see the duct here is irregular. Here is a normal pancreatic parenchyma. So this is the normal salt and pepper pancreatic parenchyma. These are the changes of early chronic pancreatitis. If you find such kind of changes, you can prognosticate the patient family. This patient is suffering from the early chronic pancreatitis. Within a few years, he is going to develop the chronic pancreatitis. Another example of young patient who presented with the biliary pancreatitis day 2, and this is a common problem which as a student you see his liver enzymes are marginally less, ALP and the gamma GGT was high, ultrasound as usual, mildly dilated CBD lower and could not be visualized. The question comes, what next? Directly ERCP, I think that era has gone. MRCP versus EUS, yes, I do agree. Such patient who has a low and the middle probability of the stone, in the 2021, you should not subject these patients for ERCP. You may deteriorate these patients. there's a pancreatic edema, the papillary edematous, you may produce a more pancreatic necrosis. So these patients should not be subjected to ERCP. Yes, if you don't have MRCP, if you don't have any EUS, MRCP is still a very good choice. But the problem is, for smaller stones of less than 6 millimeter, or the stone which is impacted at the ampulla, MRCP specifically goes up to 65% from 94%. So it is better to do endoscopic ultrasound. And endoscopic ultrasound has an advantage in the same sedation, in the same setting, in the same table. If patient has a stone, and EUS can pick up 3 to 4 millimeter size stone as well as impacted stone at the ampulla. So look at these small videos. This is a 4 millimeter lesion. You see the heteroechoic pancreatic parenchyma, mild pancreatitis with the abnormal LFT. There was a stone. And this is another patient. Look at the stone was impacted at the ampulla. Look at here, there is an acoustic shadowing. You can look at the acoustic shadowing here where my cursor is. So small stones, stone impacted at ampulla where the MRCP is not very good. MRCP is not available. Patient is claustrophobic. Patient is on the pacemaker. If patient is tachypneic, or the advantage is in the same sedation, in the same setting, in the same environment, and if possible, you don't charge for EUS and you can subject the patient for ERCP. I think EUS score over the MRCP for the smaller stones. Recurrent pancreatitis, I discussed not only the early chronic pancreatitis, many of the time when the biochemical and the imaging modalities are normal, you do an EUS and you can pick up the microlithiasis. So these are the microlithiasis, which is less than 3 millimeter in diameter. These patients, young patient who has a recurrent pancreatitis, mildly abnormal LFT, you do EUS. So the another important question is, when should the EUS to be done? If patient is stable, no LFT is abnormal, it is better to do EUS after 4 to 6 weeks. And immediate, you should not do EUS. This is important for DNB student to understand, because we got the call, patient has a pancreatitis, mildly abnormal LFT, and which has improved. As CT scan, MRCP is normal, we don't know the etiology, please do EUS. EUS to be done once the changes of pancreatitis settle down, that is after 4 to 6 weeks. So when should you do EUS? After 4 to 6 weeks of pancreatitis, you should do. If you suspect the stone, if patient has cholangitis, you should do the EUS in the same sitting. So knowing the etiology, do EUS after 4 to 6 weeks. When we talk about the pancreatic cancer, again, one-stop shopping for the diagnosis of pancreatic cancer, less than 2 centimeter, where the CT scan cannot pick up, staging of the pancreatic cancer, taking the FNA, knowing about the SMVN, a portal vein invasion, small ascites, liver metastasis, FNAC, and if required, a biliary drainage if ERCP fail, or for the pain management. So EUS is the one-stop shopping for the pancreatic cancer. In pancreatic masses, as I said, you can take the FNA not only from the mass as well as from the lymph node, and the drainage can be done from the pancreatic fluid, biliary tract, gallbladder drainage, and pancreatic duct drainage. Tumor evaluation, I'm not going to discuss in detail, but these are the another indications. If patient is a pancreatic cyst, elderly patient, you can do the alcohol injections. Pancreatic tumor, you can do the RFA replacement, because nowadays we have got an intensity modulated radiotherapy where they give the high radiation doses. So you can put the fiducial marker into the esophageal carcinoma, pancreatic cancer. So your radiological radiation oncologist can give the high radiation to the pancreas and celiac plexus block. When we talk about the pancreatic fluid collection, it is important, irrespective of the bulge, EUS is the treatment of choice for pancreatic fluid collection, either a pseudocyst or the gone. Those days are gone when you should do either ERCP guided pancreatic fluid collection. This is important request to the beginners, because in your practice, you come across with a luminal bulge. Yes, you may be successful, but the chances of the perforation, chances of the intervening vessel is there, and patient might bleed. So pancreatic fluid collection, either bone or pseudocyst, it is preferable to drain with the help of endoscopic ultrasound. And to know about the nature, other CT or MRI is the investigation of choice. T2 weighted image give about the debris. This is important for you. If patient has a WPON, it is important to do the MRI to know about the debris rather than doing the CT scan. Yes, you can do the CT scan to know about the pseudoaneurysm, but to know about the world of pancreatic necrosis, how much is the debris, it is important to do the to do the either EUS or to do the MRI. EUS has an advantage. It gives the size, it gives the wall maturity, it gives the thickness of the wall, intervening vessel, content. Does this patient is having a solid content, that is the WPUN is there or not? Rest of the pancreatic parenchyma can be evaluated. PD, CBD can be evaluated, and you can select the site of puncture. But all pancreatic fluid collection is not amenable with the EUS. This is important. As a important for you people to understand, those patients who has a periluminal collections, and especially in the lesser sac. Even the anterior to the perforation is very high. So for you student, the ideally is a symptomatic patients, centrally located, stable patient, on lesser curvature if you find a collection. These are the patient who is suitable for. So look at the just below the stomach in the lesser sac, there's a collection. All collections are not suitable for important. The important is lesser sac, just below the stomach, no paracolic extension. If paracolic extension, you do percutaneous and EUS guided, but anterior to the stomach wall or the other area where the EUS cannot reach is not the right candidate for EUS. This is important. Stable patients, centrally located, hemodynamically and symptomatic patients. Before EUS drainage, always consider a contrast CT to know about the pseudoaneurysm. You should discuss about the patient about the need of interventional radiology or the surgical backup. Adequate expertise is important. Counsel about other treatment. Check for coagulopathy. And another important thing, the CO2 facility should be available in your center. As I said, EUS scope allow for the visualization for the window of entry as well as intervening vessel. Even a small intervening window of entry there you can do with the help of EUS. If there is a no bulge, if it is away at least 1 centimeter from the gut wall, you can do EUS guided drainage. It helps in differentiating the VON from the cystic neoplasm of the pancreas. It eliminates the landmines and can aspirate and abort if you find there is a hemorrhagic content. So it is important. EUS can give the assessment. You see the contents are clear. You give the complete assessment of the pseudocyst or the VON with the help of endoscopic ultrasound. Once you assess, you can plan, does this patient require a plastic stent or the metal stent? And once you do the assessment, you puncture, and once you puncture with the needle, you can aspirate and you can proceed with the procedure under fluoroscopically. So it gives the assessment of the window, nature of the content, puncture site, fluid sample can be collected for aspiration, for knowing about the amylase as well as the culture sensitivity. Once you puncture, the second step is exchange of the guide wire. You exchange the guide wire, make 1 to 2 loop as you are doing in ERCP, 0.03 by 5 guide wire. And once you have exchanged with the guide wire, the tract dilatation, it is important again for the beginner, never use needle knife, use the cystotome 6 French or the 10 French, which is important. And once you do the dilatation of the tract, if you're planning to put the plastic stent, you can dilate with the CRE balloon of 10 to 12, 15 millimeter. If you're planning to put the metal stent, then dilate with the CRE balloon give millimeter of dilatation, give the 4 to 6 millimeter dilatation, depending upon the what kind of stent you are planning to put. Once you have dilated the tract, if you are planning to put the plastic stent, you can put the plastic stent under endoscopic guidance. You can put 1 or 2 plastic stent, or you can place the nasocystic drain. And if you are planning to put the metal stent, then you, under EUS guidance, you use either an Nagy stent or the lumen opposing stent. That has completely changed the treatment of VON because of the availability of the Nagy stent or the lumen opposing stent by the Boston. This is the metal stent which we have placed, and you can see the pus is coming, and you can go inside and you can do the necrosectomy, you can dilate, and you can go in the same session. This is the image. This is the fluoro image. Stent has gone in. This is the stent. Inner flange has inflated. This is inner flange. Pull your scope. Pull your stent. Endoscopic guidance or with the help of EUS, you can release. That's how you place the metal stent. And if this patient requires necrosectomy, then after 1 or 2 days, with the help of upper GI scope, you can go in and you can remove the debris. And debris can be removed with the various accessories. But just for your information, the Dormia basket or the snare are the best accessories for removing the necrotic debris. We have developed the system where we flush the cavity with the normal saline diluted with the hydrogen peroxide. We flush the cavity with the 1 to 2 liter of the diluted hydrogen peroxide or the plain saline. We just aspirate the material. We don't do the necrosectomy because risk of bleeding and perforation is there. So this is another way of doing the necrosectomy. Now, why it is important to know, are you dealing with a pseudocyst and VON? Because the pseudocyst has a high success rate. It can be dealt with the plastic stent, less number of procedure, less costly. While VON, the success rate is less, patient may require number of procedures are more, and patient should be tackled with the metal stent. If you go into the literature, the recent data shows there is no difference between the plastic and the metal, but there are studies which shows the metal stent is better for the VON, while for the pseudocyst, plastic stent is sufficient. So EUS guided pancreatic fluid drainage also has complication in the form of bleeding, perforation, infection, and the air embolism. That's why always use the CO2. Try avoiding using the air, and the infection is there, then you should give antibiotic. Bleeding and perforation is less. If you do with the metal stent or under endoscopic ultrasound, risk of bleeding and the perforation will be less. So EUS is safe. For pseudocyst, I suggest a plastic stent. And for the VON, it is better to use the covered metal stent, either the Nagi or the hot Axios. Just to tell you the difference between the Nagi and the hot Axios, Nagi require all step, that is puncturing the cyst, exchange with the guide wire, dilating the tract, while the hot Axios is a one-step procedure. This electrocautery, you pump, it dilates with one step, but to Nagi stent, if patient is symptomatic, then you do the necrosectomy. The presence of the solid debris in the cavity is not the indication for doing the necrosectomy. If patient has a recent onset of fever or the ongoing fever even after the drainage of the VON, then you should go inside after 48 hours and do the it's possible to take the FNA, celiac plexus, neurolysis, and pituitary drainage. As I said, EUS is better for the small CT scan. Lesion of 2 or more than 2 centimeters CT scan is equal for knowing about the detection. This is a comparison of EUS versus MDCT. These are the old studies, but EUS score for the diagnosis of the pancreatic lesion, which is less than 2 centimeter. Look at here, the 6 millimeter EUS. On contrast, people control hyper enhancement, hypo enhancement, high enhancement. Hyper is malignant, normal, inflammatory, hypo is cancer. In contrast, EUS, if it is a hypo enhancing lesion, and from where you compare with the surrounding pancreatic parenchyma. If the lesion is hypo enhancing, it is a pancreatic cancer. If the lesion is iso-enhancing,
I think Rajesh, if you put your video off, then your sound will be better. I think because of the bandwidth, there is a problem.
Yeah, some network issue.
So just put your video off for the time being. Rajesh, just put the video off for the time being. Rajesh, we can't hear you.
Require a tissue diagnosis. So EUS diagnosed the lesion. EUS stage, which was operable on CT, but we know that SMV is involved. FNA was done, and patient was proved to be adenocarcinoma, subjected to neoadjuvant chemotherapy, and followed by after 3 months, patient was subjected to the surgery. If patient is, so this is how you know the portal vascular invasion. You see this is the vessel splenoportal confluence. Here you see the planes are maintained, here the planes are lost, and here the tumor has invaded the portal vein. So if it is more than 180 degree, or the portal vein is involved on both the side, or SMV is on both the sides of the EUS, then it requires neoadjuvant chemotherapy. When it is just abutting, the surgeon can do the reconstruction of the SMV. And for SMA, I said the CT scan is the best choice. For a smaller lesion, I said smaller liver metastasis of 5 millimeter or 6% of cases of pancreatic adenocarcinoma might have a mediastinal lymphadenopathy. You can take the EUS guided FNA from these mediastinal lymph node, and if it is malignant, these patients are unoperable. So a smaller mediastinal lymphadenopathy may be present in 6% cases of the pancreatic adenocarcinoma. Small liver metastasis or a small amount of ascites, which is not visible on the CT scan, you can tap it. If it is positive for the cancer, the operable patients become unoperable. So doing an investigation which help in staging of the tumor, I think, is mandatory for the pancreatic cancer. All pancreatic masses are not cancer. If the probability of having a cancer is low, like a young patient presented with a fever or painless jaundice, and you feel it is not adenocarcinoma, FNA to be done, you may come across with the autoimmune pancreatitis, or you may come across with the tuberculosis, or you may come across the neuroendocrine tumor. So this is our paper. We diagnosed 12 cases of the pancreatic tuberculosis. So pretest probability is important. Young patient with a pancreatic mass, features not in favor of a malignancy, and even if the patient is operable, you should take an FNA. Pretest probability is high and the tumor is operable, 2 centimeter lesion. You don't even require, you just do an staging and you can directly subject the patient for surgery. But if the borderline resectable or SMV is involved, take FNA. Take the patient for radiochemotherapy, and then patient should go for the Whipple surgery. For lower end CBD obstruction, CT scan as well as MRI has poor resolution. For ampullary lesion, attention of that. Yes.
Rajesh, it's okay. Carry on. I think if you put your video off, then your audio will be better. There's some problem with your connectivity. So if you put your video off for the time being.
Is this okay, sir?
Yeah, it's okay. Yeah. But in between, we are losing your audio. Okay? Yeah, it's okay. Carry on.
So if the patient has a normal ampulla on the side wing and MRCP is like this, and if you do an EUS, look at here, endoscopic ultrasound, a thickening of the lower end of the CBD, and possibility of cholangiocarcinoma is there. Here is the dilated common bile duct, and you see a small tumor at the ampulla. So many of the gastroenterologists subject these patients for ERCP, and you don't get a diagnosis, patient delayed for the surgery. If you find a tumor, if you have a suspicion of cholangiocarcinoma, I think it is better to directly subject this patient for the Whipple surgery rather than doing the ERCP, because ERCP, you may not get the tissue diagnosis. You are making the patient awaiting for the surgery. Surgical colleagues don't want ERCP. So if you find such kind of lesion and a patient appears to be operable, it is better to subject this patient for the Whipple surgery. When we talk about the EUS guided biliary access and the drainage, sir, am I audible there?
Yes, sir. We're audible, Rajesh. It's fine. Carry on.
We can hear you.
When we talk about the EUS guided biliary drainage, then EUS guided biliary drainage is possible either from the stomach or from the duodenum. So it is possible, you know that ERCP is a standard of treatment for the biliary drainage. This is important. EUS is not the standard till today. But if the ERCP fail, either because of the fail of the ERCP, or you are not able to reach up to the papilla. So ERCP, accessible papilla, where you fail cannulation or there's a gastric outlet obstruction. So if patient is a gastric outlet obstruction, either you do PTBD or you can do the EUS guided drainage. Or ERCP accessible papilla, you have a failed cannulation, tumor invasion, or there's an anatomical variant or periampullary diverticulum where you could not cannulate the CBD, EUS guided drainage is possible. So look at an example, 75-year-old patient who has a metastatic cancer, fever with a deranged LFT, poor surgical candidate, already on antibiotics, failed ERCP. What should you do? You have an option of EUS drainage or PTBD. You know that PTBD is conventional approach with a very high success rate. But PTBD has limitation, multiple session, painful, poor patient acceptance, limited by obesity and ascites, and many of the time, patient has a catheter dislodgement. So EUS guided biliary drainage is one of the options, and this is a patient where presented with a surgical obstructive jaundice. When we did an ERCP, there's a gastric outlet obstruction. We are not able to reach up to the papilla. We did an EUS. You look at the dilated CBD. It was punctured with a 19G needle. The guide cholangiogram was taken, and a fully covered 6 centimeter stent was placed. So in the same sitting, in the same session, just change of the scope, you can do the choledochoduodenostomy, or you can do the antegrade or retrograde. There are various methods. So just for the DNB student, you should know you can do transgastric or you can do transduodenal. You can do antegrade or you can do retrograde. So 4 terms you should remember: transduodenal, transhepatic, antegrade or retrograde. These are the methods by which you can do the drainage of the bile duct. Advantage of EUS: same session, same operator, no additional resources, internal drainage, minimal, no procedural pain, not limited by obesity, and it doesn't produce hampers in the day-to-day activity. An additional advantage: shorter hospital stay, cosmetic advantages, tissue diagnosis is possible. You can do the celiac plexus block, and if patient has a gastric outlet obstruction, you can do the GJ also. So I said transhepatic, you use the segment 2 and 3. Just for a beginner, you should know segment 2 and 3 from the left lobe, you can puncture and you can do the transhepatic drainage.
এখন এই মুহূর্তে তো একটা webinar আছে, বলুন না।
Can be done either hepaticogastrostomy, or you can do the retrograde from the stomach. You can go to the left lobe of the liver and you can reach up to the papilla and you can do the retrograde or antegrade stenting. So the transhepatic, transduodenal, antegrade and the retrograde, 4 terminology you should remember. This is the guide wire, puncture from the left lobe of the liver, goes up to the duodenum, and once you dilate the tract, you can, yes. This is a hepaticogastrostomy. You puncture the left lobe of the liver, segment 3 ducts, and you put a partially covered stent into the left duct and the stomach. That is called as hepaticogastrostomy. Choledochoduodenostomy I have already shown. So biliary drainage also has a complication. This is important. And now, in the last 2 years, the complication rate has gone from 25% to 10% in the form of pancreatitis, hematoma, bile leak, or bacteremia, or pneumoperitoneum. But all these are possible to manage. Pancreatic duct drainage in a failed ERCP is also possible. You just remember as an indication, if ERCP failed, or patient has a malignant block of the pancreatic duct and he developed pancreatitis, or patient post-Whipple's where the ERCP is not possible, you can do the drainage of the pancreatic duct. So EUS guided pancreatic duct drainage, again pancreaticogastrostomy, or you can do the rendezvous, or you can do the antegrade. These 3 terms you should remember. Now, celiac plexus neurolysis, you know that it can be done percutaneous or EUS wise. EUS is minimally invasive, safe, cost effective, can be performed during staging and biopsy of pancreatic masses. 80% pain relief. Bilateral celiac plexus block is possible. It can be repeated and the less complication. So with the help of EUS, this is the aorta. This is the origin of the celiac trunk. And at the origin of the celiac trunk, you can do Look at here, this is aorta, this is a celiac trunk, and here you inject the absolute alcohol. You should remember, if patient has a chronic pancreatitis, you do the celiac plexus block. If patient has a cancer, you do the celiac plexus neurolysis. For the block, you use the steroid. For the neurolysis, you use the alcohol, absolute alcohol, 95%. At the origin, where the celiac trunk originates, you inject the absolute alcohol. It can be done bilateral. It can be done the celiac ganglion neurolysis. You inject into the ganglia. So celiac plexus neurolysis, unilateral, bilateral, extended, and celiac ganglion neurolysis. These are the 4 terms you should remember where you inject alcohol, that is called as neurolysis. In cases of cancer, in patients of benign disease, you do the block. Pancreatic tumors, novel treatment, I think no point in going, and we are exceeding the time also, but you just remember alcohol or the RFA is possible. I talk about the fiducial placement, patient of pancreatic carcinoma who require radiotherapy. You can inject the fiducial marker. These are the fiducial marker. You inject on the corners of, so the radiation give the high radiation doses and help in preparing the patient for Whipple surgery. For the cystic, last few slides, for cystic lesion of the pancreas, EUS is important because it differentiates pseudocyst versus cystic neoplasm. It differentiates what kind of cystic neoplasm, because again, you can see that is this patient require a follow-up or this patient requires surgery? Is it malignant or not? EUS guided FNA, aspiration of the fluid is possible. You know about what is the nature. I'm not going into the detail, but yes, anybody wants, I'm still able to answer after my talk on the email. So these are the various reasons. This is the serous cyst adenoma, which is small, like a grape-like structure. This is a benign. This patient don't require follow-up. This patient don't require any surgery. But if you find this kind of cystic neoplasm, which is in a middle-aged female, which has a mural nodule, this is a mucinous neoplasm, which has a malignant potential. These patients require surgery. This patient has a neuroendocrine tumor with the cystic degeneration. FNA shows neuroendocrine tumor. This patient requires surgery. And here, a hydrated cyst. This is a benign lesion. So on CT scan or MRI, if you find about the cystic neoplasm, it is better to do the EUS to know the lesion. If you know this is a benign lesion, you don't require FNA, you don't require follow-up. But if it is a pre-malignant or malignant, you can take FNA and you can treat this patient by surgery. If patient is inoperable, you can do EUS-guided alcohol injection. So EUS-guided alcohol or RFA is possible in the pancreatic cystic lesion. There is a good amount of data available. So oligolocular, that is 1 or 2 locules are there, or cyst more than 15 milliliter, you can inject alcohol. EUS-guided RFA injection is possible. These are the RFA machines. And patient who has a neuroendocrine tumor or adenocarcinoma, you can do the EUS-guided RFA. In those patients who are elderly, not a good candidate for surgery. Last 2 slides. In staging of the GI cancer, esophageal, gastric, and the rectal cancer, EUS is the investigation of choice for the T staging, limited to the musculus mucosa, not gone beyond submucosa. It is T1. Gone beyond submucosa into the musculus propria is T2. Going up to the adventitia is T3. Going up to the adventitia with the lymph node is T3 and 1. Now these are the videos. Look at here, the submucosa is intact, is T1 tumor. It has gone up to the musculus propria, is T3, and gone up to the adventitia. This is the lady who is pregnant and having this lesion. CT scan was not possible. This is the T3 and small node. And this is the example of T4, which is a tumor has gone to the prostate. So for the T staging of the rectal cancer or for the esophageal cancer and the gastric cancer, EUS is investigation of choice, but it is better before doing the T staging, you should do a CT scan and MRI to know about the N and the M staging. If patient has a metastatic disease or you know that patient has a nodal disease, then you don't require T staging in these patients. In pelvic abscess, post-operative pelvic abscess, EUS guided drainage is possible. I think for the scarcity of the time, I'm not going. But again, earlier pelvic abscess was drained transgluteally by the interventional radiologist. where the possibilities, the patient has a lot of discomfort, intervening colon and the vessel, but EUS guided pelvic drainage is a very good alternative in post-operative patients after the gynecological or the sigmoid or the rectal surgeries. EUS guided pelvic drainage is possible. Thank you for the patience hearing, and I'm ready to answer any questions which are there.
I would say, Rajesh, it was an excellent presentation. We have only 5 minutes, but I would extend the time. So we would have about 10 minutes of question and answer. Nikhil, there are a number of questions for the chat box. So maybe we can first answer them, and then if there are more floating questions.
Yeah, thank you, Rajesh, for this excellent talk. So I'll clump the question so that we can answer a few questions at a time. So there are a lot of queries regarding pancreatic fluid collections. So many of the attendants want to know why there is a cutoff distance between the cyst wall and stomach wall. What is the ideal cutoff? And so you want to comment on that?
It should be less than 1 centimeter. It should not be more than 1 centimeter, because risk of the leakage is more than 1 centimeter away from the gut wall. You should avoid doing the EUS guided. Then these are the patient for percutaneous or for the surgery.
So another common clinical scenario that the DNB students face is a patient having colicky abdominal pain with mildly dilated CBD with bilirubin or maybe 1.52. Should they directly proceed for ERCP or should they undergo EUS?
So very good question by the student, and Dr. Nikhil, you have raised. The very good paper from the Rana from the PGI. A patient with a dilated CBD with a normal liver function, there's no need to do anything, and most of the time EUS will also be normal. If a patient has a dilated CBD with an abnormal liver function, you should do EUS. You may pick up the small stone. If suspicion of sphincter of Oddi is there, then yes, you can. Otherwise, patient should not be subjected to the ERCP. If patient has an abnormal LFT, even patient has an abnormal LFT, you should not subject, because sometimes patient might have a NASH along with the pain abdomen. So it is important, you should look at the clinical scenario. Patient has a pain. At the time of pain, if the LFT is abnormal and EUS shows a dilated CBD, and even if the CBD is normal, then you can suspect about the SOD. But if the CBD is dilated with a normal LFT, you should not do ERCP. You should do EUS, and you prove that if there is a stone or the worm, and then subject these patients for the ERCP.
Thank you, sir. The question is, in case of Crohn's disease, perirectal and sigmoid abscesses, can it be drained? What are the chances of fistula if you drain EUS guided in this?
Again, a very good question. Again, a very good paper by me as well as Shyam Vardla Raju. We have done the diverticular abscess, not the Crohn's abscess. Those patients who has a diverticular abscess, the Crohn's abscess, the results are poor. The complications are. Those patients who has a post-operative collections, the EUS guided pelvic drainage is very good results and is very good successful. But Crohn's disease abscesses, which are generally small, and the risk of complications are more. So diverticular abscess and Crohn's abscess should be avoided. With an EUS, it is better to treat with antibiotic or by surgical diversion colostomy.
Another very common question that arises in DNB students: what is the indication for aspiration in cases of pancreatic cyst?
Yeah, very good question. So if you are sure about the diagnosis, you should not aspirate. A bigger question is a cyst of unknown cause. If you know patient has a benign cyst, no need to aspirate. If you know patient has a malignant disease, a 45-year-old female who has cystic neoplasm with a mural nodule, no point in aspirating. You can directly subject the patient for the surgery. A cystic lesion where you feel that aspirating is going to change the management. In those situations, you do the EUS guided aspiration of cyst, give a prophylactic antibiotic, use 19G needle, puncture the biggest size of the cyst, aspirate complete cyst, avoid transcystic puncture of the cyst. These are the free precautions you should take. Definite diagnosis, you don't require FNA. Indeterminate diagnosis, you can take FNA.
Thank you, sir. Is it possible that a patient who have unexplained abdominal pain and you find early chronic pancreatitis changes with a normal CT scan? If yes, then usually what is the lag period? Like for how long patient can have an early CP changes on EUS with a normal CT scan?
So there's only one paper which was published in, I think in I'm just forgetting the name, 5 years. 4 to 5 years, when these patients are followed, a significant chunk of the patient turns out to be chronic pancreatitis. So generally 4 to 5 years. So important thing is pain abdomen with the changes of pancreatitis is not the patient of chronic pancreatitis. Patient should have a documented pancreatitis by hyperamylasemia. And then you find the changes of early chronic pancreatitis after 6 weeks of EUS. Then you prognosticate these patients that yes, the possibility of development of chronic pancreatitis is there. This you should talk to the patient.
See, Rajesh, there has been some debate about whether these criteria are suitable for Indian population. So do you think that all these criteria are true for the Indian population as well for diagnosing mild chronic pancreatitis?
So very good question, sir. This was the question, why this question was raised, because there are many changes which was seen in the Indian patient, those who are a smoker or alcoholic. The important thing is you should have a pre-test probability. Patient should have a pancreatitis. If patient has a definite pancreatitis and you find these changes and you find 4 criteria, then yes, you follow these patients and probability of getting chronic pancreatitis is very high. And we don't have any data to say that these are the Indian criteria. Still, we have not developed any Indian criteria to say that these are the different criteria from them. The important thing is definite history of recurrent pancreatitis should be there.
I have one more question, Rajesh. If you have an accessible papilla which you could not cannulate at ERCP in a say a malignant setting, you have an option of a rendezvous technique versus a direct choledochoduodenostomy. Which one will you prefer from the long-term success rate as well as long-term complication rate as well?
I have a very good question. If the patient is operable and patient require biliary decompression, I will go with the rendezvous technique. If patient is inoperable, to prevent the stent blockage, I might do the choledochoduodenostomy or antegrade transhepatic.
Okay.
Sir, in pancreatic cancer, there's sometimes surgeons don't prefer for us to have a biopsy. So is there chances of tumors spread along the needle track? Should you biopsy all patients of pancreatic head mass?
No, I think during my talk I also discussed what is feeling of the patient is also different. He will also correct me if I'm wrong. The most important thing is if patient has a high suspicion.
So
borderline surgical candidate, like patient has SMV involvement, the candidate for the neoadjuvant chemotherapy, you have to take the FNA. For second, if you are not 100% sure that this patient is having a malignancy, you suspect the patient might have a benign disease like autoimmune pancreatitis or pancreatic tuberculosis. In those situations, you take the FNA. And number third, you are transgenerally, which is anyway going to remove your Whipple surgery. The duodenal approach, the risk of peritoneal dissemination is very less. It is 1.6%, which was known in the literature. And that is only with the one study. So, in my opinion, if patients demand, I want to move before surgery diagnosis. If a borderline operable case, the patient requires neoadjuvant chemotherapy, if suspicion of pancreatic cancer is not high, in this scenario you take FNA. The patient is operable, high probability of malignancy, surgical police don't want, you should not subject the patient for surgery. You should not subject for patient for FNA.
I can ask one last question.
Yes, Nikhil, that would be the last.
So, with the advent of EUS guided liver biopsy, pros and cons compared to percutaneous, in which clinical scenario it should be used?
Yeah, I think EUS guided liver biopsy, only 2 papers are available. So, in my opinion, till today, I think the percutaneous biopsy should be the standard of care. And recently, Shyam has published where he has given a better results of the percutaneous in comparison to EUS. So 2 or 3 papers, 1 paper favor about percutaneous, I'm talking from the EUS side, and 2 papers talk about the EUS. But I think 2021 percutaneous is still gold standard. But EUS guided liver biopsy has or may score over percutaneous in near future. Today, EUS guided.
I think, Rajesh, if this will also depend upon what is the indication for doing the liver biopsy. Are we doing a biopsy from a SOL or we are doing a biopsy to rule out chronic liver diseases to understand the etiology? I think that will also to some extent guide us, isn't it?
I think we have lost that to Rakesh.
Anyway, I think this was an excellent presentation. I don't know whether Rajesh is still there or not, but I think